Minimal hepatic encephalopathy, the diagnostic tools and clinical implications. So I'll be covering the presentation in these headlines, which is the introduction, the implications I'll be covering initially, but diagnostic tool, possible use of AI as we move forward with MHE, and few proposed way forwards as well as a proposed charge for diagnosis. So as we all know, hepatic encephalopathy is a very common illness. Close to about 11.6 per 100 patient years is the incidence. Hepatic encephalopathy is divided into covert and overt hepatic encephalopathy. So covert hepatic encephalopathy is where there are no signs and symptoms of HE, but there is cognitive impairment. And overt is which we already know, where there are other signs which includes personality changes as well as estresis and the other clinical signs. So there's a very high incidence of MHE as well as HE around the world, and it is very important for us to diagnose it right at the beginning before the disease actually sets in. So if you look at the classification of hepatic encephalopathy, there is MHE, which is right there in the beginning, which is only abnormal in psychometric testing, and that is why the name of covert hepatic encephalopathy, where the signs and symptoms are not obvious. And as it progresses, you have all the other signs of hepatic encephalopathy. So it is important, or we can say it is the most crucial part, that if we can diagnose it here, it will not lead to the further progression of hepatic encephalopathy. So the first thing I would say is minimal is misleading. Probably there can be another terminology that can be used for MHE, because as we are going to see further, that MHE is a very important tool and leads to a lot of signs. As you can see here, the progression to overt hepatic encephalopathy in patients MHE and child POG of C, so 6, that means CTP B, and somebody has MHE, they have a higher rate of progression, and it is close to 56%. So this is like a precursor of diagnosing hepatic encephalopathy, and we know how debilitating the disease can be. So it becomes very important that we can recognize it, diagnose it, and as well as treat it efficiently before we can actually progress to the other illnesses. Now coming to this slide, and this will become a very important slide, is the memory impairment which is associated with patients with cirrhosis. And as you can see here, grade 1 is 22%, and it can go up to nearly 92%. The reason why this is important is that sometimes minimal hepatic encephalopathy is confused with other states of neurological illnesses, and that is where the dilemma lies as to how do you diagnose patients with MHE vis-a-vis other cognitive illnesses like dementia, maybe Parkinson's, because that's a common problem that we face even in our outpatient department. So this was a consensus guideline. As you can see, this was in 2010, which was published in Clinical Gastroenterology and Hepatology, and they had said that the prevalence of MHE is very high, as well as they have higher rates of traffic violations, motor vehicle accidents, poor quality of life. So it shows that it does have an implication when you're looking at these patients. But what is more important to note is that this guideline was almost 14 or 15 years back, and most of the studies that have been done in MHE are pretty old, and there is not much of data in the recent times on MHE. So the impact of MHE, as I had said, includes the risk of RTAs, difficulty in operating machinery. Somebody who's a blue-collared worker may have difficulty, decreased quality of life, increased risk of falls. There's also difficulty emotional behavior, and very important, which is I've written below, is the worse sleep quality. And I think worse sleep quality is, I think, one of the initial manifestations that a patient with cirrhosis comes to you in the outpatient department. So this is a case. I'll come back to it in the end, but I'll just ask people to just observe it. So this is a 65-year-old male. He's a shopkeeper. He's unable to work. According to him, he's not able to sit in his shop. He's a diabetic, hypertensive. He has an history of ethanol usage. He was diagnosed by a neurologist with Parkinson's disease. He has certain memory impairments. He has history of fall, and there are certain baseline tremors that he has. He has been on a combination of carbidopa and levodopa. However, the persistence of confusion continues, and now recently he's come to the neurologist with an increased disorientation to time and place. They did a CT, they did not show any major infarcts. However, for the first time they saw that the platelets were 91,000, the bilirubin was 2.2, and the INR was 1.6. So this is a patient who has been persistently followed up in a neurology OPD. However, let's see what happens subsequently. So coming to the assessment of MHE, the compilation of the cognitive defects in MHE is also known as SONIC, which is spectrum of neurocognitive impairment in cirrhosis. So they mainly include changes in attention, working memory, response inhibition, as well as the executive function. So the diagnostic tools that have been developed for MHE have included the 5 of them, which are the psychometric hepatic encephalopathy score, which is the most widely used and validated score. You have the smartphone applications, which are easier to use, less time consuming. You have the animal naming test, and there are certain new scores, which are the BAB score and the MASC-HE score, which can be used. But it must be kept in mind, most of these tests have been around for nearly 15 to 20 years, and their application worldwide is still a difficulty even in today's scenario. So like I said, there is no single optimal measure for diagnosis of MHE, because none of the diagnostic strategies cover all the aspects of defects that are present in MHE. So coming to the first one, which is the most extensively validated, is the PHS score. This is a paper pencil test. It evaluates your cognitive, psychomotor processing, speed and visuomotor coordination. It consists of the number of the NCTA, the NCTB, the digital symbol test, as well as the time and error test. Now they've been around for a long time, and they're very easier to administer as well. So coming to the first one, which has also been recommended by most of the guidelines, the number connection test. Now a number connection test, if I was to simply put, it is these 25 numbers which have been placed, as you can see here, serially. And all the tests that you have to do, the patient you have to ask is, he must connect the numbers in order, in the shortest time possible. So what you're trying to see is that if somebody has 1, then he has to connect to 3, and then 4, and then 5. So the least time that he takes is where you can actually diagnose him with MHE or HE. And it's abnormal when the test scores are more than 2 standard deviations. We normally say PHE a score of less than 4, which includes the other 5 as well. Now there was a slight variation for the number connection test A, which was the number connection test B. And what they've done in that is that, including the numbers, they've also added the alphabets. So the patient is asked to connect the numbers and is also the letters in an alternating manner. So it becomes 1, and then A, and then 2, and then it becomes B. So this is again a test that was which was proposed as a variation of the number connection test. The digital symbol test is basically 9 pairs of numbers and symbols that are present at the top of the chart, as you can see here. And the target is to draw a symbol which is related to the number in the lower portion. So right here. So if you can see here, this is 8. So the symbol would be an I over here. So this is what you ask the patient to do. And again, it is considered abnormal if there are less than 2 standard deviations. All these tests can be easily done in the OPD, but they are extremely time consuming. And the biggest fallacy with all these tests here, they are age dependent as well as also based on the education. That has been the problem. And even for the line tracing and serial dotting, which we can commonly do even in our wards, is to just show that, the line tracing that can be done as well as the serial dotting. So coming to the next one, which was a sickness impact profile. Now this initially was a 136 statement questionnaire which was measuring the quality of life. However, now you have a shortened version which is known as the SIP covert hepatic encephalopathy. It does identify MHE with a sensitivity and specificity of 80 to 79%. However, as you repeatedly do the test, the specificity goes down at 6 months and 12 months. So that's an issue. It's only a good baseline test, but probably not when you're trying to evaluate the patient over again. So this was an article which they had used this validation of this test in minimal hepatic encephalopathy. These patients are all a Danish cohort of patients of 110 patients with cirrhosis. Their MELD was around 11. And for the SIP scoring, what they used was gender, age, and they used 4 statements. So the 4 statements were: I do not maintain balance, I act irritable or impatient with myself, I'm not doing any physical activities, and I'm eating much less. So based on that combination, they found out the scoring and looked at 82%. But if you look at the specificity, it was only 38%. And that is where the problem lies, that other neurological manifestations can also mimic MHE, and hence these tests have to be extremely specific for us to actually say that this is due to MHE and not due to any other cause. And also it lead to a higher incidence of OHE at the during the follow-up. So this is where the clinical implications of covert hepatic encephalopathy becomes very important. So coming to the computerized test at the point of care. And the first one, which is again a very old test, is the inhibitory control test. This was a computer-based analysis which was to look at the attention and response. So the patient is exposed to these flash lighting, as you can see here, XOLY. And there are something called as lures. Now the lures can be that after an X you should normally have an O and L. But what they can do is they can have another X which can come in between over here. So that's when the patient has to pause the test and then say that this is incorrect. So this again is based on the inhibition of distraction, which is very important for patients. So this looks as your attention and your response inhibition while you are showing these test mechanisms. A very, very old study in 2008 had looked at these methods to diagnose MHE as well as to predict overt hepatic encephalopathy. And they had shown that patients who were on psychometric tests and ICT and patients with MHE had a significant lower, so they were unable to correct the mistakes. That's the important part, and a lower target response as compared to those without MHE, and more than cutoff of more than 5 layers. So if they made mistakes more than 5 times, that's where they could diagnose MHE with a sensitivity of 88 and a specificity of 77%. But this has not been commonly used anymore, and the applicability still remains an issue with these tests. So the other common test that is normally advocated is the Stroop smartphone application, where the initial study was to include 125 patients and 134 controlled. And what you normally do in a Stroop test is that you have something called as an on-site and an off-site. An on-site is where they ask you to label the color which they show, and the off-site is where they ask you to label even if red is written and it is in green, so you have to say that it is in green rather than in red. So that is the on-site and the off-site, and there are 5 sets with a run of 10, and well, the normal value here is 155. We were well within the normal value. So you diagnose MHE with if it is more than 197 seconds. That's the amount of time that a patient's MHE would take in completing these tests. But it is very important to note that these tests, when the Stroop application was made, it did not include patients who had alcohol-related disorders, and most of these patients were only with viral hepatitis. So the actual dilemma of diagnosing patients with an alcoholic degenerative disease or other concomitant illness has not been found out in this test. So this, again, the application is slightly off color. So as you can see, this was a study long time back in 2013, where they looked at the sensitivity of 78% and specificity of 94% for all patients who were off time or on time. We can call it now off-site and on-site, which is the latest terminology which is used. So even though this seems to be a very easily applicable test, it can be easily downloaded on the phone, that it can be done. However, a study which was done in 2021, and these were all cohorts from the US cohort, and they looked at the acceptance and the use of smartphone application in cirrhosis. So they took 102 patients who looked at the predictors of acceptance and utilization, and what they found out was that you either needed the presence of a caregiver, and there should have been controlled ascites for people to actually use this application, and only 71% agreed to download the app, and only 32% actually use the app. So the usage of this app in a country where there, even with high levels of literacy also, was only 32%. So the actual applicability of a computerized survey, I think, is still under question mark, and maybe an easier survey or better outreach is required for these sort of applications to work. So the other is the animal naming test. It's a pretty simple test which requires you to name as many animals as they can in 1 minute. It is again influenced by the age and education, and hence that is a limitation of most of the tests that I have already described. And this was a very recent article where they reported animal naming test in terms of frailty, and they found out that 8.2% out of these group had a poor ANT performance, including with poor health status and frailty overall. But again, the actual mechanism as to how would an animal naming test cause an increase in debility or frailty is pretty much under question. And very importantly, the animal naming test is not specific to cirrhosis or chronic liver disease in this spectrum. So we are almost left with no other test. Most of the tests are not specific in this dilemma. So some of the other proposed tests which are used for prediction of hepatic encephalopathy is the BAP score, which is bilirubin, albumin, non-selective beta blocker usage, and the statin use. And a MELD sodium activity chair stand quality of life hepatic encephalopathy index. It's a very complicated test. So a risk score to predict the development of HE in this patient. This was an hepatology article. They used about nearly 2,000 cirrhotic patients who did not have hepatic encephalopathy at baseline. This was a retrospective cohort, and their outcome was to measure the development of overt hepatic encephalopathy over a 5-year period. And what they found out was 43% developed HE within 5 years, and they calculated a score, and the score was, if it was less than 10, 27% had a risk of developing HE, and if it was more than 10, 49% developed the risk of HE. But it is more important to note is this statement which uses that use of statin was associated with risk of developing HE, and non-selective beta blockers use was associated with higher risk of HE. Now this is a very debatable and a controversial topic, because none of the mechanisms have been stated as to how statin would cause a reduction in HE and why would a beta blocker predispose somebody to HE. But this was the conclusion of the study. This next score was recently done in 2021, where they took 294 patients with child A and B cirrhosis with portal hypertension without HE, and 62, that is only 21%, had HE over a period of 1 year. And what they did was they combined these 5 activities, which is the MELD sodium, the chair stands, the quality of life HE score, the short form A, and the impact on activity rating and chair stands within 30 minutes. So that's why the score has this name. And what they found out was the area under the curve at 12 months was 82% as compared to 55, 61, 70 and 72 compared to the other scores that I had already mentioned. So they formed a decision tree as to how you could diagnose, and this is the decision tree. As you can see here, the impact on activity. If the impact of activity is less than 3 and if the score of 8 is less than 71, your chair stands, if they are more than 5, you look at the MELD sodium, and if the MELD sodium is less than 10 and the chair stand is more than 80, you achieve a sensitivity of nearly 80% with this score. Again, this is a decision tree, and most of these tests can be subjective and maybe not very specific for patients who have hepatic encephalopathy because of liver cirrhosis. Now another test which has been actually been validated quite a few times is the critical flicker frequency. And the critical flicker frequency is a visual test which measures the frequency when an impression of a fuse light turns on a flickering one. And what has been shown is that a cutoff of nearly 39 Hz has a higher sensitivity specificity of diagnosing these patients with minimal hepatic encephalopathy. In fact, one of the earliest studies was done in GB Pant in 2007, where prospectively 156 patients who did not have HE were enrolled, and the incidence of HE was nearly 53% and 80% at a CFF of less than 39, with a very good sensitivity and specificity. So this seems to be a very simple and reliable test. There was another study which was published in Gastroenterology in 2016, which had again looked at the similar outcomes, and they looked at survival. So they tried to correlate CFF with survival. And what they found out was if you had a MELD of between 10 to 15 with MHE, this 5-year survival was 44%. And if you had a MELD between 10 to 15 and no minimal hepatic encephalopathy, you had a survival of 61%. So they were able to correlate CFF with the development of minimal hepatic encephalopathy and also with survival in this group. However, very recently in Hepatology in 2024, they have compared 6 tests for prediction of minimal hepatic encephalopathy. And they've used the 6 tests, which is the PHEHS score, the animal naming test, CFF, inhibitory control test, the smartphone application, as well as the continuous reaction time. However, on this study, on this basis, what they have postulated that none of the tests were specific and only an abnormal PHES score were linked to the development of minimal hepatic encephalopathy. And if you look at the patients who were neurologically unimpaired versus patients who had grade 1, you can see that PHES was able to diagnose in nearly about 100% as compared to the other group of patients. So this was a very recent study on this. So they do say that PHES score is possibly still the most sensitive test for diagnosing of minimal hepatic encephalopathy in this group. So as I've discussed all these tests, but the key question is most of these tests have been around for nearly 15 to 20 years, but none have found an applicability in the clinical scenario. The PHES test, which is probably the most validated test, is insensitive to early changes. It is influenced by age and education, and of course extremely time consuming also. The inhibitory control test, even though it's very rapid, you need to have familiarity with digital computers, a high level of functional levels. EEG also, though I have not touched upon it, EEG has not shown to be very specific for minimal hepatic encephalopathy, but quantified EEG has been shown to have some role, especially with the visual evoked potential. And the smartphone application, as I've already said, has certain issues, including the age, education, the training of using the app, which may take some more time. So there are a lot of limitations that are involved with these tests, and possibly there is a need to develop more tests or a different way of diagnosing patients with minimal hepatic encephalopathy. So the only other thing that can come up to our mind is artificial intelligence. And using artificial intelligence, there is an app which is called as Hear Me. And Hear Me is an app which is readily available on your smartphones. And this is an app which uses your voice recognition to actually diagnose, discuss your problem. So it can be a financial issue, it can be a personal issue. So the Hear Me uses a voice recognition to actually be able to connect with you. It's more like a chat box which is there, and this is readily available on the internet. So actually there was a study in 2020 which looked at the language impairment in adults with end-stage liver disease with natural language processing. So in short, natural language processing is what we use in our smartphone, which is a Siri or an Alexa on an Amazon device. So it uses your voice, it recognizes the voice, and using a language processing is able to deliver the information that you require. So what they did was they took 81 liver transplant recipients, at least one recording of a patient to provide a message which was pre-transplant and post-transplant, and they matched it to healthy controls who had similar disease but were not evaluated. So they were possibly cirrhotics, but they were not in a stage where they required a liver transplant. So what they found was that MELD more than 30 had a decreased word length in a pre-transplant message as compared to a post-transplant period. And MELD with 30 had fewer 6+ letter words, and they had an increased sentence length pre-transfers compared to post-transplant. An example would be that if a patient says that I have been called to the OPD at such and such time, and somebody would say I have been called on this date. So the word count reduces. So in a pre-transplant period, if you would observe, most of the patients have a higher word length and a word count which is there, and they have shorter words. So this can be one tool to actually indicate if somebody has any cognitive impairment using a language processing. And then there was some work which was published in American Journal of Gastroenterology, where they looked at the slow speech, and they looked at patients who had hepatic encephalopathy, and they found out that speech rate, the word duration, and the use of certain words were much more common in patients who eventually developed hepatic encephalopathy. So what they found out, anybody who has a history of overt hepatic encephalopathy had a slower speech and a longer word duration. So it also tells us that when we are taking a history of a patient, even a careful history can also tell us sometimes even minimal hepatic encephalopathy, and maybe in future applications which can actually diagnose HE based on certain smartphones can be used in this group of patients. Now coming back to the case which I had discussed, so this was a 65-year-old who was a shopkeeper unable to perform his activities, or diabetic, hypertensive, significant ethanol intake. He was a case of Parkinson's disease, was on therapy, but there was still confusion, and he presented to the hospital or initially to neurology emergency with low platelet count, bilirubin of 2.2 and INR of 1.6. Now this is a very common problem. We get it in our OPD basis. They've been on long duration treatment from a neurologist. However, it turns out that there was asterisks on clinical exam. When you actually looked, the sodium, the ammonia levels were high. When an abdomen CT was done, it was nodular. There were collaterals, a high fibroscan. So they were started on lactulose rifaximin. However, the rigidity persisted, and that is where the role of bromocriptine. So this is an entity which is known as an hepatic Parkinson. So it's a very overlapping entity that we normally see in patients who have minimal hepatic encephalopathy. I've not been able to go into the details, but it is important to note that patients who present with other forms of cognitive impairment can also have form of hepatic illness. So it's important to look at these subgroup of patients to effectively diagnose them. And this was now recently shown in a paper from JAMA, where they used patients who were having dementia. So these were patients, nearly about 10 lakh patients. These were all veterans, and they were on a visit to the OPD with dementia. They did not have a prior diagnosis of cirrhosis. And when they actually just used the FIB-4 score, they found that 18,400 patients actually had cirrhosis. And when you looked at it, and they actually, once they were treated for patients with hepatic encephalopathy, there was much more improvement in their confusion as well as the other state. So this diagram actually tells us that the difficulty that we have in diagnosing patients with HE. You have an overt hepatic encephalopathy, you have a Lewy body dementia, which is again an elderly form of dementia that can occur, and you have a Parkinson's disease dementia. And as you can see here, all the diagrams are pretty much together. So it becomes very difficult at times to make a diagnosis. However, a high grade of suspicion is required when you're trying to diagnose a minimal hepatic encephalopathy or even a grade 1 hepatic encephalopathy in patients presenting an alternate diagnosis. So some of the questions that need more answers is whether MHE will evolves with exacerbation and flares. So what is the period of exacerbation and flares? What are the precipitating factors that may worsen? So we still do not know what precipitates an MHE to go on to an hepatic encephalopathy. What are the significant interactions of MHE with other neuropsychiatric entities? Are they aligned with one another, or are they a different spectrum altogether? And what is the severity? Does it lead to an irreversible subclinical cognitive defect which cannot be corrected by transplant? Well, some of it was answered in that digital paper, but that still nobody studied that pre-transplant minimal HE, did it recover post-liver transplant? And also would imaging in such scenarios, so we commonly do a lot of imaging. even though there have been studies which have looked at hepatic encephalopathy and the role of imaging, there have not been specific answers. Some of them say that if there's a reduced brain water volume, it can predict hepatic encephalopathy, but these are still not very specific for us to actually look into this spectrum. So I think we need newer diagnostic tools, maybe a use of AI, we use voice features, demographic data, look more specifically at MRI of patients who have cognitive impairments due to other diseases with hepatic encephalopathy and normal controls, and try and compare all the three spectrums and see what overlaps and what is distinct to the three populations. And very commonly for our country, maybe a validated score which is in our own local languages. As you would see here, most of these scores were either inhibited by age or by education. So we need to probably develop more scores which are in the local language of our country for their better adaptation in our policy. So this is up for debate where any cirrhotic. So according to the ASLD guideline, all patients of cirrhosis have to be screened for minimal hepatic encephalopathy. However, it is a time consuming and a big challenge. So what I thought was that maybe we can ask for an history of nighttime sleep disturbance, memory impairment, difficulty in calculation. So this is something I've learned from Sir's OPD, where when we ask somebody to calculate from the backwards of 100, where you reduce 7, a lot of patients have a lot of difficulty in this calculation. This is, I think, one of the earlier markers of minimal hepatic encephalopathy. You look at abnormal conversations, maybe look at longer sentences, ask them about their work, whether there's difficulty in driving or in their this thing. And all patients with CTP of 8 and MELD more than 15 probably should be screened with CFF, which is readily available with us. It is validated. EEG is still a question mark, but it can still be done, and maybe studies can look at certain specifics that an EEG can look. A number connection test A and B, once we have diagnosed somebody to have an abnormal CFF, maybe then we can go in for the psychometric test and look at ammonia levels. And even if they do not have these symptoms, to rescreen them every 3 to 6 months once they come to an OPD, and hopefully have an app which can help them in an earlier diagnosis of minimal hepatic encephalopathy. Thank you.